Hey, this is Dr. Bill with just the tip of urology school. This segment talks about priapism, a prolonged, painful erection. Well, remember that most urologists have a vibrant practice in erectile dysfunction. Everyone gives out or prescribes Viagra type medications, though it is touted in the literature as a potential risk factor. I've never really seen priapism from the use of Viagra, Cialis, or Levitra. However, it can occur. It's been reported. When you think of priapism, think of a urologic emergency. We've got to determine real quickly whether this is ischemic, meaning lack of blood flow, lack of oxygen. That limb, that penile shaft is dying. And when we have an erection longer than 3.5, 4 hours, that's when our patients are told to call us, and we have to take it seriously. There are a number of medications. There are a number of occurrences, including intracavernosal injection of vasodilators that can be the offending agent. There's an extensive list on your core curriculum under priapism in the AUA. We look at blood dyscrasias. Certainly, sickle cell disease is a big factor. Multiple myeloma, the use of hemodialysis, malignant infiltration, local cancers or distant cancers with metastatic disease to the corpora can result in malignant infiltration of the corpora and result in priapism. TPN, interestingly enough, because of potential fat emboli. Hormonal use is touted to do this as well. Toxins from spider bites and various forms of trauma. When you're examining, well, first of all, when you get a call, then you have to determine real quickly what's been going on. What were the events that occurred prior to this? And when you are in doubt, those patients go to the emergency room and contact your backup urologist for assistance. When you're examining that patient, either in the clinic or in the emergency room, you want to look for a corpora that is rigid and tender with soft glands. That usually means ischemia or lack of blood flow, lack of oxygenation. That's 95% of what you will see in patients who present with priapism. A partial erection that is non-tender with the soft glands usually means non-ischemic. You're getting enough blood flow and oxygenation to keep that tissue healthy. And this is not an emergency. And there are a number of things outlined in the protocol that can be utilized. There's something called stuttering or intermittent erections that are prolonged, resolve spontaneously, but obviously that is of considerable concern to the patient and partner. There are a number of things that can be done in a non-emergent setting. If you have the availability of arterial blood gas evaluation, that is a good way of objectively determining whether this priapism is ischemic or non-ischemic. If it's ischemic, it's an emergency. Don't wait for these tests. Ultrasounds, MRIs have been touted to be of value, but normally they are not available in the emergency room setting. When we look at ischemic priapism, there are a number of things that can be done. Aspiration, utilizing alpha sympathomimetics to constrict the vessels. And again, there is a good protocol for that outlined. If it is non-ischemic, again, not an emergency, but patient needs follow-up. And when you look at one of the more common blood dyscrasias, sickle cell disease, we can use hydration and alkalinization, as well as oxygenation support to help unsickle those cells, if you will, and improve blood flow. So again, don't be frightened by this, but understand that this is a potential emergency, and the potential for permanent erectile dysfunction can occur. And because of that, that is a huge medical, legal issue when you encounter these patients. So cover yourself, do the correct things, and as always, ask for your MD for support whenever you're uncomfortable. Look at the outline on the American Urologic Association core curriculum. There are a number of other resources for information that are outlined there as well. Read the chapter, get the basics, and enjoy it. Dr. Bill, with just the tip of urology school.